This afternoon's tomorrow's oral presentation is going to highlight a number of important studies in rare lymphomas. One of those is the JACKPOT8 study, which studies a drug called Golidocitinib, which is a orally available JAK inhibitor in peripheral T-cell lymphomas. Most drugs that are currently available for that population in the relapsed refractory setting only have a response rate of 25 to 30% and a duration of response mattering in just a couple of months. Golidocitinib, at least seen thus far in their 118 patient study, has an overall response rate of 44%, and at a median follow-up of 6 months, the median duration of response has not been reached, which is quite promising. I think it's a little early, and we're looking forward to more long-term follow-up of longer-term toxicity, and can those patients be bridged to transplant from that study? But I think that represents a novel class of medicines in this patient population for which it's much needed. The average patient who has relapsed refractory peripheral T-cell lymphoma, their median survival is only in a matter of months, only about 9 to 10 months. And those who can achieve a remission sufficient to go to transplant can be cured. And so finding orally available agents that are accessible for patients and are well tolerated and can bridge people to that goal or as palliative therapy is very important. The other study that will be highlighted during that session will be the incorporation of Mogamulizumab to CHOP for newly diagnosed transplant-ineligible acute T-cell lymphoma leukemia. So that's a population for which there's a significant unmet need. Most patients, a vast majority of patients, die within months of that diagnosis. And while combination chemotherapy remains the standard, and the response rates can be as high as 50, 60, 70%, the duration of response is really limited to a couple of months, 5, 6 months at max. And patients who are younger and fit and have donors and can get into an allotransplant are considered for allotransplant in first remission. But most patients with this disease are older, not candidates for that approach at all, and getting them into remission is very challenging. So this group had studied using Mogamulizumab, which is a CCR4 humanized antibody, in combination with CHOP in acute T-cell lymphoma leukemia, and demonstrated that the overall response rate is close to 90% with this. And while the durability of remission is suboptimal, I would say, it's certainly better than what we have standardly available, and a regimen that can be given to older adults using a CHOP-based approach, as opposed to more intensive chemotherapy approaches that are really only limited to younger patients. And the third important study is a study that was that's called IELSG37, which is a study of primary mediastinal B-cell lymphoma. Primary mediastinal B-cell lymphoma is a very, very rare type of B-cell lymphoma. It has a unique biology compared to diffuse large B-cell lymphoma, and predominantly affects young people. So the average age is in the 20s and 30s. Most patients are female, and most approaches in the pediatric space have really utilized using radiation as consolidation in this patient population, using a CHOP-based paradigm. Patients have been studied to use EPOCH without radiation as well, and that's been really adopted by many adult providers as well. And in this AYA population, there's overlap between pediatric approaches and adult approaches. So this study looked at patients who completed their standard chemotherapy, which could have been at the investigator's discretion, and at the end of treatment they had a PET, and if their PET was negative by the Lugano criteria, then they did not go on to receive radiation. And the over 90 plus 99% of patients did extremely well without receiving radiation for consolidation, saving considerable toxicity, because as you can imagine, patients who are young who receive mediastinal radiation are at risk of cardiovascular complications, including heart disease, heart failure, valvular disease, hypertension, as well as secondary cancers, notably breast cancer, lung cancer, and GI cancers. So decreasing the long-term toxicities in a population where we fortunately cure the majority of patients is exceptionally important.